Yeah, respiratory diseases are increasing globally in absolute number. First, for obvious reason, the population growth and aging, and they are mainly increasing in the countries with low and middle socio-demographic index region. In rich countries, the absolute number continues to grow, but if you correct for age, the rates are in fact declining. Now, the reason for these increase, the reasons are, as I said, the aging and growth of the population, the increasing risk factors. Smoking is obviously the leading factor for chronic respiratory diseases, but environmental and both indoor and outdoor pollution are relevant. The climate change, we discuss later, is also affecting this development, and the other are the socio-economic conditions that, with the increasing number of proportion of the population in low middle income countries, the risk of diseases, chronic diseases, and of the consequences of chronic diseases are increasing in these countries that have poor health care system and large underdiagnosis, particularly of the chronic respiratory diseases. Well, in fact, that document was not a paper, so there are no data there, but it's an editorial that I wrote actually an interview that I gave in the occasion of the publication of major large American studies showing that smokers, independently from the presence of chronic diseases like asthma and COPD, were actually affected as much as the patient with mild COPD particularly. And in that occasion, I mentioned that on one side there is an information from lung cancer that there is really no threshold of smoking for absence, total absence, no risk in non-smoker, probably because there are other risk factors, but that's one point. But the major rationales to make that strong statement is that no smoker can be considered healthy, because smoking is affecting the lungs, but not at the same time, simultaneously, they are affecting almost all relevant organ systems: brain, heart, vascular, kidney, joints, and because the smoking has a systemic effect that probably targets the endothelium of the different organs. So if you smoke, basically you have to assume that you have some abnormalities in your body, and the first being that being addicted to smoking is a disease itself. There is an addiction to illegal drugs or exposure to pollutants. Yeah, the message is education, 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 education. I think that our educational system has a very small portion devoted to the healthy living, and smoking is particularly a target. You know, if you know exactly the risks connected to active and even passive smoking, you are, aware of, you are less ready to take that risk. If you know that the small pleasure that it provides makes you dependent and makes you at risk of developing such a cumbersome risk. Adolescents represent a crucial challenge in smoking cessation because they are more vulnerable. And dynamically, the interaction between adolescents is influencing each other's, and so behavioral intervention could be important. And also, they are not stimulated to have access to the facilities where you can quit smoking if you started. We know that a proportion of people that develop COPD, particularly in older age, actually up to 30–40% have early life events, adverse events, starting from prematurity to exposure to smoking of the mother and the father, to viral infections in the early age, to asthma in the early age. So a third of the patients that we see with full-blown COPD in the 60s could be prevented by intervention, active intervention in these risk factors. Yeah, it is one of the main culprits. I mean, I think that now reached the third position after cardiovascular and cancer. But these figures are administrative figures. In fact, most of these people who die of COPD, and it's estimated to be a proportion of the 300 million that are affected by COPD, that if you could diagnose and treat, probably they could survive long. So it is a major cause. The problem is that even our intervention in COPD occurs too late. Why? Because the disease is slowly progressive. The symptoms are non-specific. Is a breathlessness, dyspnea, is fatigue, and it's easily associated with an effect that a price you have to pay to the pleasure of smoking, without understanding that is a major risk factor. And there is no active plan to search early, as we do with hypertension, with dyslipidemia, with other risk factors apart from smoking, because we don't have any studies conducted in this part of the patients between the 20 and the 50-year-old that actually have a mild form of the disease, early mild form of the disease that could be potentially reversible. Only one study has been completed in this population. We desperately need to conduct study in these patients. Well, obviously, they should be, at least in our system, in my system, in Italy, but in the countries with the public health system working, they should be the doctors that actually suspect and diagnose the COPD, and they treat it or they refer it to specialists. However, as you well know, now there is a very limited number of doctors, general practitioner with solid internal medicine background, and they are overwhelmed by elderly, multimorbid, severe patients, so they do not have the time to work to actively search early diseases. They are good, the organization of general practitioner claim that they are interested and develop the guidelines, but in fact, nothing is significant is really happening in this area. It's a good question, of course. There is evidence that both outdoor and indoor, particularly for allergic asthmatics, pollution is relevant for the inception of asthma, so for the development of asthma, but is not really a major risk factor. It's an obviously global factor that has to be taken care, but is not firmly demonstrated that increase the risk of developing asthma. By contrast, there is strong evidence that both outdoor and indoor pollution may worsen asthma, may trigger asthma attacks, may increase the severity of the resistance to treatment of asthma. So asthmatics should be advised that to avoid both indoor and outdoor pollution. As you know, since many years, there are warnings in some areas. Los Angeles is the example where you have the TV saying, look, there is an increased pollution. If you have asthma, stay home. Don't go out. Don't run in a traffic side, on the side of traffic roads and so on, because they are demonstrated. By the way, once again, the indoor and particularly the outdoor pollution is also related to general risk of acute events, particularly the cardiovascular. They are not only respiratory toxicant, they are also systemic toxicant and particularly affecting the respiratory and the cardiovascular system. Now, the really major area that is the timely, early, accurate diagnosis. We have to change our mind because chronic respiratory diseases are the respiratory component of multimorbidity, and we have to develop tools, biomarker functional or biochemical and early symptom detection that allow us to make the diagnosis early. Early diagnosis is critical if you want to take to identify the disease in a potentially reversible stage. Obviously, in doing this, particularly the multimorbidity, you have to look at the complexity of these diseases. We have been educated, our textbooks, the horizon actually is divided by system, respiratory system, cardiovascular, kidney, and so on. Real life is not that way. I mean, you have complexity, and we have to be able to identify different phenotypes and treat them with personalized treatment, using effective treatments that are not just targeting one disease, but they are targeting a mechanism that may be responsible of different components of these multimorbidities and their long-term complications. This is the pandemic of the millennium. With the aging of the population, the number of people with multimorbidity will affect more than 30% of the population, particularly the most fragile, the elderly, and they need to be managed with the same skills that the very specialized doctor has, but specialized doctor needs to be trained in handling, in diagnosing, assessing severity, and using properly the treatment for the different components of multimorbidity. Obviously, we have advances that are helping us in this respect, and artificial intelligence is becoming a fundamental tool to understand more and also to manage better this complexity. And we have hope that the artificial intelligence will become more and more a tool for the doctors. It's not there to replace the doctor. It's there to help the doctor to do better his job, her job in this respect. As it has been demonstrated, by the way, already in, starting from the simplification of the administrative document to the major advancement in analysis of imaging and also of major contribution to help and support in searching for difficult cases, even rare diseases. Now, I think that to be very specific, the breakthrough of the last 10 years have been the development of biologic agents, monoclonal antibodies or small molecules that target specific mechanisms that actually are relevant in a minority, well-defined part of the population. These drugs have provided major advancement both in the treatment of COPD, mainly the treatment of COPD, but more recently also in asthma. The most recent drug is just a novel bronchodilator, so has no major effects on the patient population, but is an add-on drug that can improve bronchodilation, can increase on top of existing therapy. And interventional pulmonology has made major advancement with up and down, thermoplasty for asthma, or valve replacement, volume reduction surgery have been developed, and that have been. Another aspect is the improvement in imaging, particularly of the CT scan chest of the chest. Computerized tomography of the chest has helped for the early diagnosis of lung cancer, but simultaneously may help to detect comorbidities by looking carefully at the imaging. And I think that these are the major advancement of the last year. The other that is ongoing daily is the application of artificial intelligence in clinical medicine that is obviously quickly developing in the well-organized and rich countries, and is much slower in different countries. In designing the new system, particularly the hospitals, but also the hospital for the community hospitals, there are major investment. They are part of the European support given by the European Union to develop technology that allow you to be in contact with the health system without going there. And that's one point. The other point is that cardiopulmonary rehabilitation, that is a very effective treatment for chronic diseases of different nature, but particularly respiratory and cardiac, can be equally effectively delivered by using telemedicine, changing again the life of. So I'm very supportive of telemedicine and remote monitoring for chronic respiratory, but also cardiovascular diseases. That I think that they represent a major advancement of the last 10, 15 years. Yeah, one of the major problems we have in all chronic diseases, and particularly, but not only, respiratory diseases, is adherence. Because particularly for risk factors, take an example, blood pressure, glucose, lipids, cholesterol, physical activity. I mean, these have to be done independently from symptoms. And one of the major issues is that the people affected by the disease, particularly asthmatics, for instance, most of the asthmatics are mild, moderate, and under adequate treatment, they become asymptomatic. The only risk they incur is now and then some exacerbations, asthma attacks, mainly due or partially due to the fact that they discontinue treatment. Asthmatics tend to discontinue because they say, there is this concept that drugs are to be taken only when you need it. By contrast, there is evidence that most of the risk factors that have been identified, and the three examples are, hypertension, hyperdyslipidemia, diabetes, but also COPD. Regular long-term treatment with adequate therapy is actually not only improving quality of life and decreasing symptoms, but also potentially preventing death. I mean, they increase life expectancy.